So I just would like to welcome everyone to our meeting tonight. And as we begin our talk, our lecture, I would like to ask everyone to pause for a moment for a short prayer. Let's pray. Our loving God and our Savior, we would like, Lord, to thank you for this beautiful evening. We thank you, O God, for again, you have given us this privilege of learning together with our colleagues from different parts of this world and mostly from India. Welcoming them in our meeting tonight, Lord, as we discuss about ankle and foot ultrasound. Heavenly Father, we pray that Thou will take care of each one of us, being frontliners wherever we are. Can you spare us, O God, from COVID infection? And may we continue, Lord, to serve our patients. Thank you, O God, for the wisdom and for the opportunity that we have tonight. In Jesus' name we pray. Amen. So welcome, everyone. And I just would like to share my screen, but also I would like to ask Pash to do something while I'm doing the lecture. Okay. So I'm going to first share my screen here. Can you see my screen, Pash?
Yes, Dr. Jim, very clear.
Very clear. Okay, good. So this is the part 1 of the MSK Ultrasound study of the ankle and foot ligaments. So we're focusing right now on ankle ligaments and foot ligaments. This is a very long topic, so I divided this into actually 2 parts. I hope it will not be too much for you if I have to request that. So this is our first topic on the MSK ultrasound study of the ankle and foot ligaments. Now, this is very interesting because a lot of our injuries in the foot happen in the foot ligaments and ankle ligaments. And so I am so interested to share with you what I found out in the study of this ultrasound. So first, I would like to read this beautiful text from the book of inspiration in Isaiah 40, 30 and 29 to 31. God gives power to the weak and to those who have no might. He increases strength. Even the youth shall faint and be weary, and the young men shall utterly fall. But those who wait on the Lord shall renew their strength. They shall mount up with wings as eagles. They shall run and not faint. So this is a very good inspirational thoughts for all of us as we begin our study tonight. And hope this will also inspire us as it did to me. So ankle joint complex. So here, we will first deal with the ankle joint complex, which is made up of your talocrural joint. Some people call this the ankle mortis, the subtalar joint, and the distal talofibular syndesmosis. So here, if you look at the illustration, the talocrural joint is actually formed by the distal part of the tibia and fibula together with your talus. And this is a hinge joint by function, and they are supported by different types of ligaments that you're going to discuss a little later. Then, of course, we have your subtalar joint, and this is the joint just below your talus together with your calcaneus, and it has 2 distinct joint cavities. And of course, these are separated by sinus tarsi and canalis tarsi. And this allows, of course, movements in pronation and supination. That particular portion of our discussion is very interesting, but it will be discussed in the part 2 because it's so intricate and it's so detailed that it will take a lot of time. So just watch out for the part of this lecture so you will be able to see it. And then, of course, we have the distal talofibular syndesmosis. And this is the joint between your tibia and the fibula at the distal part. And these are also stabilized by a different set of ligaments. And to name a few, it's stabilized anteriorly by the anterior inferior tibiofibular ligament. And of course, it's right here. Then posteriorly, we have your posterior inferior tibiofibular ligament. And of course, the interosseous membrane, which is found right in between that structure. So that's the ankle joint complex. So here at the talocrural joint, which is formed by the distal tibia and fibula, we can see a lot of ligaments from the anterior portion. And so what we see here, for example, when you put your, when you consider this part, is that you can see a ligament right here at the distal portion of your fibula, attaching it to your distal portion of your medial part of your tibia. And this is your anterior inferior tibiofibular ligament. And of course, distal to that, you can see a distinct ligament right here, which is what they call the Bassett's ligament. We will go through this ligament a little later. And then, of course, below that, we have your anterior talofibular ligament. This is the most commonly injured ligament in our ankle, especially for sports injuries. So if you look at the talus is actually wider anteriorly than it is posteriorly. That is why for a stabilization of this joint, you have to dorsiflex the ankle, and that actually fits more, or we call it in a closed pack position, and that gives you more stability. But if you do your plantar flexion, as most ladies do when they wear high heels, then it articulates with a smaller width of the talus, and that makes it very, very unstable. And so most of the time, the injury happens when the foot is inverted and it is plantar flexed. And then, of course, we have your syndesmotic ligament complex, which is the one responsible for resisting both your axial, rotational, and translational movement. And that also stabilizes your tibia and, of course, your fibula. Now, there are three ligaments, as mentioned earlier, that stabilizes the ankle mortise, and we have mentioned that already. We have your anterior inferior tibiofibular ligament, which is shown here at the previous slide right here. And then, of course, we have your posterior inferior tibiofibular ligament, and this ligament is composed of the superficial and, of course, the deep layer. Sometimes the deep layer, they call it the transverse ligament. And then, of course, we have your interosseous tibiofibular ligament. So that is actually the area right in between. So these three ligaments are the ones that stabilizes the ankle in a more proximal portion, or I would say even in the higher portion of the ankle joint or the ankle mortise. Then interestingly, we have a structure just below the distal tibia, which they call the synovial fringe right here, which actually lowers and rises during ankle movements. And of course, it also retracts in dorsiflexion to rise and descend in plantar flexion towards the ankle joint. This is very important because sometimes when we cannot find the cause of pain when we put our weight on the ankle, seemingly that area is very susceptible to pain. And if there is a chronic pain right on that area, then the injury could have injured the synovial fringe. And this usually happens following an ankle sprain. And this may cause your soft tissue impingement, or sometimes what they call as the syndesmotic impingement. So that is what happened with this structure called the synovial fringe. Now, also, when we look at the syndesmosis, so right here is a more detailed structure of the ligament. So right here, for example, you can see the anterior inferior tibiofibular ligament right anteriorly, and then posteriorly you can have the posterior inferior tibiofibular ligament, and of course right in between that you have your interosseous ligament, or sometimes you call it membrane. But the reason they call it ligament is because it's also a very tough structure to deal with. So because of that, it's considered to be the structure that also stabilizes that distal part of the ankle. We call it the syndesmotic ankle ligaments, or what sometimes is injured, especially in what they call a high ankle sprain. So as mentioned earlier, it is linked by the anterior inferior tibiofibular ligament, the posterior inferior tibiofibular ligament, and of course the interosseous ligament, which, as we mentioned, they sometimes call it the interosseous membrane, but actually it's contiguous with the more proximal part of the interosseous membrane that's coming from the middle third of the tibia and fibula going down to the ankle. Now, the posterior inferior tibiofibular ligament, as we mentioned earlier, is composed of the deep and, of course, the superficial. And we mentioned also that the deep part, which was shown in the previous slide, is sometimes called your transverse ligament. So if you are considering an injury, for example, of this particular structure, there is a sequence of injury that could happen. The most susceptible of the three is your anterior inferior tibiofibular ligament. So you can always check on this first if you are thinking about a high ankle sprain. Then followed by that structure, of course, is your interosseous ligament, the one in the middle, and rarely, sometimes about 10% of that is the posterior inferior tibiofibular ligament. So it's very interesting that it's really rarely that you include this, but sometimes if you include this, there's really such an injury to the ankle that sometimes it is already including the deltoid ligament to some extent. Now, let's go and take a look at the anterior inferior tibiofibular ligament. So again, right here, okay, so this is your anterior inferior tibiofibular ligament. Then of course, there is another structure, as I have mentioned earlier, and that structure is the one that is distal to that, which is a very distinct structure. This is a part of the anterior inferior tibiofibular ligament, but it's a small ligament right at the edge of this attachment right here, and they call it the Bassett's ligament. Now, Bassett's ligament is usually significant when there is an injury of the anterior talofibular ligament. So, for instance, this ligament here, which is the most commonly affected, if there is any injury here, what happens is that the talus moves forward, and as it moves forward, as we have explained, the anterior part is narrow, the posterior part is wide. So when it becomes lax and unstable, the talus moves forward, and as a result of that, the Bassett's ligament now is causing some attrition injury right here between your Bassett's ligament and, of course, the part of that talus that is articulating in this area. So that kind of injury will sort of cause an impingement on that area, usually the forward movement as a result of the forward movement of the talus because of the injury of the anterior talofibular ligament. Now, to image that area, so this is the way to do it. So usually what we are familiar would be your anterior talofibular ligament. So if you are coming from this area here, all you have to do is to move your probe close to about 80 degrees going up. And then the first structure that you can see would be your Bassett's ligament. And only when you move it a little upwards would you be able to see the anterior inferior tibiofibular ligament. So for instance, in this case here, this is the anterior inferior tibiofibular ligament. And so if you move it a little downwards, then you can see the Bassett's ligament. So again, it's preceded by an ankle sprain involving your anterior talofibular ligament. Now, these are different structures that we see. Okay, so this is, for instance, your anterior inferior tibiofibular ligament. And as we go down, this is your Bassett's ligament. As we go farther down, we can also see the dome of the talus. That is the one that is being affected in an anterior ankle impingement. So right here again is another structure. We have the distal interosseous membrane, or they sometimes call it an interosseous ligament. And so you can see here that it's a fibrillar structure that you can see a little above that area. So it's not so distal, but once you've seen the malleolus right here, where you can see all those ligaments that we have described earlier, you just have to move your probe a little upwards, then you can see this structure. It's made of the distal interosseous membrane. And this is the second most involved structure in high ankle sprain. Now, the mechanism of injury in this syndesmotic sprain is that, let's say there is an eversion injury, which happens here in this illustration. So the structure that could be involved, as we've explained earlier, is the anterior inferior tibiofibular ligament, followed by your interosseous ligament. And if it is really a very severe type of injury, of eversion injury, it could involve the deltoid ligament, but rarely, as I mentioned, about 10%, it could involve the posterior inferior tibiofibular ligament. So another illustration here is that this is an eversion, axillary rotation ankle injury. So you can see here the anterior inferior tibiofibular ligament, and you can see here how this organized in bizarre the patterns. There's loss of fibrillar pattern in this area, and there is a widening of the gap between the talus and the, should I say, between the tibia and the fibula. And this is a full thickness tear of the anterior inferior tibiofibular ligament. It is retracted. The ligament is redundant, as you can see it. And then, of course, the widening of this interval between the tibia and your fibula. Now here is another example of the anterior inferior tibiofibular ligament. As you can see, there is thickening of this anterior inferior tibular ligament here. If you look at this shadow here, it's almost a loss of fibrillar pattern, and there's swelling. But look at the complete AITFL tear, where you can see that there is already a gap in between, and there is a widening of the space between these two areas right there. And then, of course, this is another example of a normal AITFL versus a complete tear of AITFL. So these are good examples of all these structures that could be involved in an ankle sprain that involves your syndesmotic ligament. Now, in an interosseous membrane injury, to be able to see if there is any involvement of the structure, it's actually a non-visualization of this normal fibrillar pattern. So let's say, for example, this is the intact interosseous membrane. When you look at the abnormality right here on the left part of the illustration, you can see that you don't quite see any fibrillar pattern here. There's loss of that pattern, which is giving it an impression that there is an injury that happens at the interosseous membrane. And of course, the ligament right there. And then, of course, the posterior inferior tibiofibular ligament. So what you need to do is just to adjust your probe. So it's like a V sign. So from the anterior inferior tibiofibular ligament, slide your probe going posteriorly. And what you can see is the posterior inferior tibiofibular ligament. And we have the superficial and we have the deep. And the deep is sometimes called the transverse ligament, as we have mentioned it earlier. Okay, and this structure in the deep forms a labrum over the talus, and it provides posterior talar translation. So if there is anything that could prevent that area from moving posteriorly, it is because of the deep posterior inferior tibiofibular ligament. So this is a very important structure in stabilizing the ankle posteriorly, because the absence of that structure would actually cause that kind of problem in the process of walking or even in sports activities. So how do we scan them? So the position of the previous one anteriorly is right here. So what you have to do is to move your probe and just move it posteriorly this way in a V sign, okay? And then you go to your posterior inferior tibiofibular ligament. So this is how it looks like, the posterior inferior tibiofibular ligament. And as I mentioned earlier, it's rarely injured in the high ankle sprain, unless maybe there's such a strong injury that happens that could involve that particular area. But otherwise, it's rarely that it is involved. So the injury, again, as we have mentioned earlier, is caused by an excessive external ankle rotation or a combination of ankle dorsiflexion, adduction, or abduction of the foot. So that is how it happened. So it's mostly an eversion type of injury. And then, of course, the last ligament that could be involved is your posterior inferior tibiofibular ligament. So the sports that you can actually see this is in ice hockey, skiing, American football, rugby, wrestling. And then, of course, it could be stable or unstable. So what do? If it is stable, in other words, it only involves the AITFL and interosseous ligament. So you just treat it conservatively. Put a cast, cold compress, do physical rehabilitation, and then do an intensive follow-up of that kind of treatment over 3 to 4 weeks. And so that is what you do for the treatment for a stable type of injury. However, if it is unstable, in other words, it not only involves AITFL, but it involves the deltoid ligament. There is involved with the interosseous ligament, and to some extent, your PITFL. Then, of course, there is no other option but to do a surgical treatment. Now, it's been suggested here that PRP can be given 10 to 12 days post-injury with shorter return to activity. So you might ask, why 10 to 12 days post-op? Usually in an injury like this, it usually will settle down in terms of swelling and inflammation at the time, and that is almost like 2 weeks after the injury, and that is the right timing that they suggest that regenerative treatment should be started. Now, this is a different type of syndesmotic injuries. It could involve the distal, could involve the proximal or the entire interosseous membrane, as you can see it. And there is a lot of detachment that may also include some bony detachment from together with the ligament. And then, of course, the fixation that they use. Some of you may be surgeons here, and so there are different types of intervention that you can do depending on the type of injuries. Now let's go to your medial ankle. Now the medial ankle is also very interesting because it's almost like a sequelae of the syndesmotic ligament, because as you can see, it is an eversion type of injury in the syndesmotic ligament, and then of course your deltoid ligament right here. Now there's a lot of deltoid ligament, but I just would like to emphasize here that not everything in the ligament is consistent. In other words, there are other ligaments that you think there is, that you can see, but actually you don't see all of them. And the only regular or consistent ligament that we see here are these three: the tibionavicular ligament, okay, you can see it right in front, okay, going to the navicular bone. And then we have your tibial spring that comes from the tibia, and then it inserts into the spring ligament right here below, which is actually the superomedial calcaneovicular ligament. This is the superior portion of the spring ligament complex. You will notice here that there is just a lot of ligament also that forms the spring ligament. And then, of course, the deep posterior tibiotalar ligament. So in other words, these three are the ones that you can consistently see all the time. Now, if, for instance, you don't see tibiocalcaneal ligament and the other ligaments that you expect to be part of the deltoid ligament, then that means those are the ligaments which are not regularly or consistently seen. So only look for those three which are always present, because you don't quite see all of them all the time. So here is a study by two groups, by Milner and Swamis, and of course Sarafian. And you can see here that there's just a lot of other ligaments that we know. And we thought all of them could be seen regularly, but as I had mentioned earlier, only the tibial spring, the tibionavicular ligament, and of course, the deep posterior tibiotalar ligament are the ones that are always present. The rest could be present, but could also be absent at the same time. So the one that provides you strong, more important for ankle stability, is of course the deep posterior tibiotalar ligament. Now right here, these are the ligaments that are always present. So let's begin with the posterior tibiotalar. This is a deep ligament. So it's very difficult sometimes to see this because as you will notice, it is deep and it is right horizontal from the tibia going this way. Should I say here? So it is a very short ligament, okay, but it stabilizes a lot of these ankle movements from in its eversion motion. Then of course we have your tibial spring ligament. It is superficial. From here it goes all the way to your spring ligament, the superior medial portion of the spring ligament right here. Then of course we have your tibionavicular ligament. It is also superficial and it goes all the way to your navicular bone. So these three, the blue, the yellow, and the lavender right here are the ones that are consistent. The rest, the tibiocalcaneal are not consistent. So the other ligaments are not also consistent. So you don't quite see them all the time. Then of course, let's go first to the posterior tibiotalar ligament. This is the thickest of the medial ligaments. That's why it holds the medial side of the ankle very strongly. It stabilizes it. It comes from the upper segment of the medial malleolus, inserts on the medial surface of the talus under the tail of the articular facet. And of course, you can do a dynamic imaging of that. And so this is how actually it looks. It looks like a fan actually. So right here. Then of course, this ligament could also be torn in spite of the fact that this is very strong, and this will cause a lot of instability the moment this ligament is affected. And by ultrasound, you can see it to have a loss of fibrillar pattern, as you can see right here. It's just a dull hypoechoic area, and you don't quite see the pattern that makes up the ligament. So that is a complete tear of that particular ligament. Then of course, the tibiocalcaneal, which we mentioned to be not consistent, but it could be present in about 88% of patients. And all you have to do is just to bring your probe this way, going down on a vertical motion right here at the medial side, and you can see the tibiocalcaneal ligament. So it's superficial, so you can see it. The depth is just very, very shallow. Okay. Then we have your anterior tibiotalar ligament. So this one is also a very thin ligament. It originates from the medial malleolus right here and inserts at the medial surface of the talus, just distal to the anterior part of the medial talar articular surface. So you can also see that structure very nicely this way. So it's very thin, so it doesn't give you a lot of instability the moment it is affected during an eversion injury. So here, the medial eversion injury would not only affect actually the ligament, but also the capsule of the ankle. And of course, there is a rotating component that comes with it. And this represents 15% of all ligamentous injury. That's not a lot, because you don't quite see eversion injury happening very often, but it could still happen, and it is so important to consider how you actually can see them in an ultrasound picture image. Or it could be a combined superficial and deep tear in this case. So you have a loss of fibrillar pattern, and you can see it's so heterogeneous, or it could just be the deep layer of this particular area. So when is the best time to image this? So weight-bearing radiograph should be done 3 to 10 days post-injury. Sometimes because of the swelling, because of the edema, you don't see the picture very clearly. So it is better to do it 3 to 10 days post-injury. Or with ultrasound, you can do it very quickly. You can actually see the injury right away with ultrasound. And so you can judge based on the findings whether the deltoid ligament is involved or not. Now let's go to your lateral ankle. Now this is the most commonly involved injury in the ankle. So the lateral ankle sprain, as we always used to call them. Now, if you will notice here, as we have mentioned earlier, the most commonly involved is the anterior talofibular ligament. Now here, there are two parts of this ligament. We have the superficial, which is intra-articular, and we have the deep, or the inferior band, which is, or the inferior fascicle, sometimes they call it, which is extra-articular. So this one is intra-articular, this one is extra-articular. Now note also that with this ligament, if you will follow this ligament, you can see another structure posterior to the inferior fascicle, and this is your calcaneofibular ligament. In fact, this inferior band of ATLF, or TFL, I should say, is connected with the calcaneofibular ligament. Later on, we will discuss what is the implication of this being connected together, or they originate from the same area in the fibula. And so we will see that this is actually a complex right here. But suffice it to know that there are two bands that forms the anterior talofibular ligament. Then of course here, this is another cadaveric study of how this is connected to each other. So if you will notice, the superficial part is not so much connected with the calcaneofibular as that the inferior bands right here. So it makes a complex actually right here. Now we will not discuss these ligaments right here yet. There's a lot of them, but we will just focus on this area first. So in the lateral ankle, we have what we call, of course, there are some studies that says that there is no such thing as lateral talocalcaneal ligaments. There's a study that was made by Vega in 2020, okay, which says that this particular ligament here doesn't really exist. Although some studies is in 2016 by Pau and his colleagues, of course, identify this to be a distinct ligament, but recent study did not say this is really existing. So it's just the superior, the inferior, and of course this calcaneofibular ligament right here. Now, so the most frequently injured, of course, we know it's anterior talofibular ligament, and it is usually the most superficial that is affected more, and then 20% of that goes with calcaneofibular ligament right here. And of course, as we mentioned, there are superior bands, intra-articular, and inferior bands with the extra-articular, and in between the superior and inferior, there is actually an artery here. It's a perforating peroneal artery, and that is the reason why when there is an ankle sprain, you can always predict that there could be also bleeding and hematoma because of the structure that lies right here in between that area. I will show it to you a little later. And then of course, it stands in ankle inversion and plantar flexion, as I've said, because that's the most unstable position because of the shape of the talus. and also because of the fact that when you actually plantar flex, your ligament is on a very tense position. Now, when you plantar flex, the inferior band actually relaxes while the superior band is taut. And when you are in the dorsiflexion, the superior band relaxes and the superior band is taut. So depending on the grading, of course, we say grade 1 is a stretch, grade 2 is a partial rupture with mild instability, and grade 3 is a complete rupture of ATFL with mild instability together with a CFL. Then we can do some other tests like drawers together with an ultrasound guided, and of course the tailored tilt test, which is also a high sensitivity at 98%. So now this is an example of your superficial layer of anterior talofibular ligament right here in the neutral position. And when you do an anterior drawers test, this makes it more visible. You can see it's very conspicuous in terms of the fibers of the ligament. And then of course, here you can see that there is some rupture between your insertion into the fibula, where it usually happens in the anterior talofibular ligament. Now they're saying, of course, there's another one. You can do a reverse anterolateral drawers test. And they were saying that this is even a reliable test for chronic ATFL rather than just the anterior drawers test. Of course, depending on what you are comfortable of doing, you can also do that. You do the reverse thing. And then, of course, we're shown here with a normal ATFL right here, okay? And of course, this is an acute torn ATFL versus a chronic torn ATFL with calcification. So as you can see, usually it's hypoechoic when it's acute. So right here, you can see a lot of edema and of course, blood maybe along this area. But the moment it becomes chronic, then you can see some calcification that is existing, and it's usually echogenic. And you can see that it has been there for quite some time already. So that is just to differentiate between your acute torn ATFL versus that of the chronic torn ATFL. And then if you're doing your dynamic ultrasound, doing drawers test, this is how you can position it, okay? Your probe, and then you try to see what happened with the torn ligament right here when you apply force, and then you can see how that tear is opening up every time you do a stress test, whether you're doing it in the usual drawers test or the anterior drawers test. Now, this is what I wanted to show you also, that there is an artery that lies over that area. And that is the reason why every time we have an ankle sprain injury, then that also could be involved. And that is why there is always hematoma that goes with it when you have an ankle inversion sprain. Now, if you highlight that some more, you can see here that it's actually relatively large. If you look at it, and it goes all the way at the portion of your anterior talofibular ligament right here. So can you just imagine, if this is the one that is most commonly involved, the superficial structure, then this also could be involved. And usually the tear would happen at the proximal part. So it would surely cause bleeding of this blood flow, blood supply right here. Okay. So majority of these heal without complications, and about 25%, 40% sports-related injuries, and 20 to 40% may have a prolonged dysfunction because of chronic lateral ankle instability. So return to play usually may use reconstruction, as I've said, if it's grade 3, or if you start a rehabilitation program, it's suggested that you start at 2 weeks of immobilization and then shift it to progressive weight bearing and functional rehab. And of course, in the presence of osteochondral lesion, you do weight bearing only after 4 to 6 weeks. There could be some bone that is detached, okay, that osteochondral lesion could stay there. And then of course, you have to postpone the weight bearing after 4 to 6 weeks because you would like it to go to a safer place, or that it would not impede on the area between your tibia and of course your talus if that happens along that side. Then of course return to play 3 months among elite athletes, and then of course 87% if after surgery. If there is a persistent pain, then look for osteochondral lesions. Then if it is present, then what you can do is you do an arthroscopy prior to doing a surgery, or you can use to some extent brace, and of course reconstruction if it is needed. Now let's go to your calcaneofibular ligament. So this is the only ligament that connects the talocrural or the ankle mortise and the subtalar joint. So if you will notice, it goes all the way up, passing through the talus, then inserts into your fibula. So it really traverses two joints right here. It is horizontal in extension and it is vertical in flexion. So just remember that. So if you do your flexion motion, then the structure becomes vertical, but if you extend it, then it becomes horizontal. So it is relaxed in valgus and it stands in varus. Now, because of this structure, some people, as I've mentioned, like the research done by Dr. Vega in 2020, she's saying that there is really no lateral talocalcaneal ligament. And I think he is correct in saying that, because this might just be a fiber that is already part of the calcaneofibular ligament right here. Or there could be a combined rupture of ATFL and CFL. Usually, a combined rupture of ATFL, we're referring here to the deep ATFL. And of course, the CFL, because they arise from the same origin at the fibula. And of course, isolated CFL rupture is very, very rare. So what you do is you dorsiflex the foot and then put your probe almost parallel to the leg. And then you can see here that actually the calcaneofibular ligament goes all the way up. Actually, from here at the calcaneus, it goes all the way up right here to the fibula. So it actually wraps around this area. And the reason why we only see black here because of anisotropy, because they are actually vertical in this position here. So it goes all the way right there. And then if you will notice, there are two tendons here in short axis, and these are your peroneus brevis and of course peroneus longus here. And usually, if this ligament is intact and you apply dorsiflexion and plantar flexion, when it is taut in dorsiflexion, this will actually be moving up. In other words, the calcaneofibular ligament will push this going up. Okay, but if there is any rupture, okay, of this ligament, if you do a dorsiflexion, these two tendons right here will not move. Okay, now just in case you would like to do and you would like to check if there's an involvement of the calcaneofibular ligament. So after doing this should I say, this in-plane long axis view for the calcaneofibular ligament, then what you can do is you do a transverse view of this in order to see if there's any fluid around the sheath of the calcaneofibular ligament. If there's a fluid around the sheath of the calcaneofibular ligament, then that means you are dealing with a grade 1 calcaneofibular ligament injury. Okay, so here, so rupture happens 15% at the fibular attachment and 60% at the calcaneal side. So it's more common to have the rupture happening at the calcaneal side more than the fibular side. So this is very important in stabilizing the lateral ankle during load bearing. And of course, you can still see here the blood supply in that area. Okay, this is another way of doing it at 20-degree plantar flexion versus a 25-degree dorsiflexion. So you can see here how the muscles, how the tendons, I should say, becomes lax in plantar flexion, and of course how it becomes taut in dorsiflexion. But of course, as I mentioned, it wraps around this area. So what you can see here is just black on this area because of the anisotropy, because the tendon, the ligament of that area is in vertical orientation. Okay, so this one is a complete rupture of the CFL. So this is the rupture here. It's on the side of the calcaneum, and so you can see here that there is loss of fibrillar pattern, and then of course there's a swelling that you can see here. Okay. Now, the combination of the inferior fascicle of the anterior talofibular ligament together with the calcaneofibular ligament forms a complex, and we call it the lateral fibulotalo-calcaneal ligament complex. So as mentioned earlier, this superficial layer is intra-articular. This inferior layer is extra-articular, but then they have the same origin from the calcaneofibular ligament. So this forms a complex, and in fact, there are fibers right here. They call it the arciform fibers that connects the calcaneofibular ligament with your inferior fascicle of the anterior talofibular ligament. And that is why, since they have their own origin and they are usually injured at the same time, then that makes it a complex. So right here, so maybe what they may call the transverse ligament right here is actually the arciform fibers that attaches the deep layer of the ATFL and of course the calcaneofibular ligament right here. So this is the one that may be composed of lateral fibulotalo-calcaneal ligament complex. And these two ligaments are isometric ligaments. In other words, in all range of motion, they do not change their tension from dorsiflexion to plantar flexion. They are all just the same. So this is an isometric ligaments, and it does not heal after rupture. Of course, there are of course some intervention that we can do for this particular ligament, but saying that this does not fully heal when it ruptures is also an overstatement, because it could still actually heal when we treat it properly. Okay, so here the superficial fascicle will give you a micro instability. In other words, when you injure this part, it will just be a very minimal instability. But I've said, if you remember in the first part of my lecture, when you rupture the superficial layer, what happened is the talus moves forward, causing impingement of the Bassett's ligament over the portion of the talus. So this is also very important, because if you don't fix them, you will always have some kind of an impingement on the anterior ankle. But at the same time, if you injure these two, which is actually the lateral fibulotalo-calcaneal ligament complex, then it will be the classical instability that could occur in the lateral ankle. And then, of course, as I have mentioned, this could repair by surgery, and this could be fixed. So essentially, if this is the one that is involved, then it is also very important to check the status of the calcaneofibular ligament together with the inferior fascicle of the anterior talofibular ligament. So during plantar flexion, okay, this is how it looks like, okay, with the arciform fibers. And then during dorsiflexion, this is how it looks like. So there is really no change. The tension is the same throughout the full range, throughout the range of motion in the ankle. So the clinical relevance of this is that in ankle sprains, the superior fascicle is the first and only one affected. With higher forces, it could injure the lateral fibulotalo-calcaneal complex. And then, of course, with continuous higher forces, it might rupture also the posterior talofibular ligament with associated lateral ankle dislocation. So in other words, if you are already seeing a lateral ankle dislocation, so maybe you have already injured the posterior talofibular ligament. And then of course, when you injure both of these, referring to the inferior fascicle and CFL, then you will cause mechanical ankle instability. Okay? Now, isolated tear in ATFL is about 80%. Combined rupture is about 20%. And of course, it could heal with immobilization, as I have mentioned. And then of course, if PTFL is also injured, there is a lateral ankle dislocation, but with only your superficial fascicle involved, it's only a micro instability that could happen in the ankle ligament, affecting the ankle joint as well. So the first line of diagnostic tool, because the X-ray, if you remember, will take about 2 weeks before you can actually see some good changes, is that you do an ultrasound and look for ATFL and CFL. Now, as I have mentioned earlier, when you do this, you might not really see, if it's just a stage 1 ankle sprain or CFL, you wouldn't see any findings here. So the best way is to do a short axis view of this CFL. And if there's a fluid around the sheath, then that means there is a grade 1 CFL sprain. So the ultrasound is very useful. It is very sensitive and very specific for that particular structure. Now we go to the posterior talofibular ligament. Now, coming from the anterior talofibular ligament, all you have to do is to slide your probe posteriorly, and there you can see the deep ligament of the lateral collateral ligament complex. And this posterior talofibular ligament is intracapsular but extra-synovial. And the greatest strain for this is when you actually dorsiflex this. Very hard to see, actually. Very, very hard to see. Although you just have to put it just posterior to where your ATFL is located, then you can quite see exactly where it is. So it is commonly injured. The ligament is relaxed in neutral position, in neutral and plantar flex, and tense in dorsiflexion. And of course, we have also another ligament right below that, the posterior intermalleolar ligament. That is also very important, present about 81.8%, and also tenses during dorsiflexion, relaxes during plantar flexion. And of course, it could be trapped between your tibia and talus, and it could be cause for posterior impingement of the ankle. Now, these are the grading system that they use. Okay, we'll not be dealing more on this. Okay, and then of course, the treatment that they use, ankle brace, elastic support, wobble board exercise, of course, boots, they're using all of those. So right here, this is the posterior talofibular ligament right here. So as you can see, this is just posterior, just slide it posteriorly, and then you can see it right on this particular area. Or you can also go step by step, go up first, and then down until you reach the third button. And so you can spot it at the middle portion, and there you can see the layer of the posterior inferior posterior talofibular ligament, I should say. Now, what is the criteria for the return to sports? Now, this only shows to me or to you that there's just a lot of algorithm on what to decide. How do we decide on dealing with all these ankle injuries? So there's just a lot of ways that we can actually do. So you create your own depending on those variables that is present right here. And the return to sports, it's not time contingent. Although if you are dealing with real professional sports, at least 3 months would be okay for them. Maybe not everybody would be happy because you would like them to involve in sports right away. but you can see here that it is very, very progressive. There's the road to recovery is just so much different. It doesn't follow a very exact pattern of recovery. So there's just a lot of variables involved. So thank you very much for your time. And I hope you learned something. And if you have any questions uh, or you would like to review this afterwards, we will post this in our YouTube channel, Mask Ultrasound. And there is a part 2 for this. So we'll give an announcement to where that part 2 is. That part 2 is more complicated and lots of details.
Thank you. Thank you very much, Dr. Jim. We really enjoyed this lecture so much. Surprisingly, it is a short lecture because it's divided into parts, but nonetheless, it's a very good lecture with all the visuals. Dr. Jim, so I guess this lecture, I would just like to comment about the emphasis maybe for doing treatment, meaning to say interventional treatment, because although there are there are blood supplies to the area, but we see that it's not as many as we want it to be, right, Dr. Jim? So like interventional treatment is something that we can do for chronic cases. Although it wasn't discussed so much here, could you like give us an advice about until when can we actually consider doing some interventional treatment if ankle sprains do not heal and if they're chronic?
Usually, it's the golden period of recovery that you have to see is at least 2 weeks, because 2 weeks is actually where you do an X-ray, and 2 weeks is also where, well, ultrasound you can do it right away, and then you can see whatever changes you expect it to be. But usually, we advise that there should be a delay of at least 2 weeks before you do anything, because you expect that there might still be something that you would like to see, because there's just a lot of edema in the beginning, especially if you are dealing with the more common, the anterior talofibular ligament. You have to really see whether you're dealing with the superficial. Of course, we know it's more superficial most of the time, and then it will cause microinstability. And as we have mentioned earlier, the microinstability can cause the talus to move forward and cause an ankle impingement by causing attrition injury over the portion of the talus where the Bassett's ligament is rubbing against that area. So that you have to really see, because it will in time be causing a lot of problems in the patient, and you would wonder, why is my patient not improving anyway? So to me, there's no hard and fast rules for this. You have to see all areas that is involved. Now, if you involve CFL, that means you involve also the deep layer, which is the inferior fascicle. And since that is a complex, and as I have mentioned, in order for you to at least say that it's a grade 1, aside from doing a long axis view, you have to do a short axis view of the CFL in order to see if there's any fluid around the sheath. If it is present, then you're dealing with a grade 1 CFL injury.
Yes, we'd like to ask some of our attendees here if you have some other questions. Maybe Dr. Jem or Dr. Brian. Dr. Jem,
Hello,
yes.
Doc Jim. Good evening.
Hey, yeah, Aaron. Nandiyan ka
Thank
pala.
you for that very wonderful lecture. Um, I was actually about to ask the same question with Doc Bashi, as to when is the best timing for doing an initial scan. And it was really good that you included the one for return to play. That is actually really a continuum. I was just also wondering in relation with that, do you do subsequent scans, or and how long is the interval? And then also, a common question athletes and some of the coaches would be asking is do you really expect like healing in those injuries like 3 months after, or for repeat scans? What do you actually really expect to see after on those repeat scans?
Okay, as mentioned, the sensitivity and specificity of ultrasound is very good for ankle injury, especially the ligaments. So you can do it right away. during an injury, but not X-ray. Not X-ray. You need at least 2 weeks for 2 weeks after the injury to do an X-ray, and you have to do a weight bearing just to differentiate whether there is an osteochondral lesion versus if it is just a regular ligament injury. Now, the mechanism of injury is very important. So let's say you are sure that it is an ankle inversion injury. There's no rotational component. Then all you have to do is just to focus on the area. Let's say it's an inversion. Then you look at the anterior talofibular ligament. But of course, we are just in the first part of the ankle, because in the second part, there's a lot more injury that you can expect, which you can also check. But let's say you are just dealing with the common anterior talofibular ligament. So all you have to do is just to repeat it every week, ideally every week. And the hematoma, of course, you just have to assure your patients there's really insignificant thing about the hematoma, because it's part of the injury. If there's an injury, you saw the artery right there that traverses the ligament, so you expect it to really be injured if there's a ligament injury. It doesn't say that if there is a grade 3, grade 2 injury, you have hematoma, and then if there is grade 1, there's a hematoma. It really doesn't follow that way, although we were taught like that before. So regardless of whether it's a hematoma or not, you just have to scan it every week. And then 3 weeks is actually an ideal return to play for elite sports. In other words, athletes who wanted to play right away, and you have to really take care of them. But maybe for regular sports, you can make them return a little earlier or maybe a little later, depending on what you see, if there's any instability. Now, the interesting part in this studies is you can do the physical examination, the drawers test, the tilt test, together with ultrasound. And so you can see if what you are seeing is correct. So if you do a reverse or you have to do a drawers test, then you can see whether the ligament is really injured, whether it's a superficial, it's the deep, then you can decide. Now, let's say it's the deep part. The moment you see a deep anterior talofibular ligament, always check the calcaneofibular ligament at the same time, because they come together. They always come together. So although there's an isolated CFL of about 20%, but if you see something that is really happening in the deep part, you have to check the CFL all the time.
Thank you, Dr. Jim. Really amazing lecture. Thank you. Really comprehensive, Doc.
Yeah, thank you, Byron.
Hi,
Thank you.
Doc.
Yeah, there.
Good
Thank
evening,
you,
Doc.
Hi, Jem. Yeah, happy birthday to your mom.
Thank you, Doc. I just have
You're still there, huh? I like
overtime, Doc. Overtime.
that.
Nice, very good lecture, Doc. Thank you so much. Recently, I also had patients with ankle injuries. One with ATFL and also another with deltoid. My question, Doc, is like, since we already know that there's a high incidence of them to develop micro instability, when would be the best time, or is there any room for orthobiologics in preventing these instability in the future, Doc?
Oh God, that is a very good question. Okay, let me just qualify that word microinstability. So if it's a new concept actually in the whole area of ankle, so microinstability is when you only injure actually the superficial layer of ATFL.
Okay.
Because otherwise, if there is a specific instability, then we can mention also the deep layer together with the CFL, or it could extend up to your PTFL, PTFL, where there could be a dislocation that could happen at the same time. But just in case there's nothing like that, it's just the micro instability. Then the other thing that you need to do is to do a dynamic imaging of your Bassett's ligament. Go a little higher, then go to your Bassett's. Just put your probe above first. Look for the anterior inferior tibiofibular ligament. Go down, you see the Bassett's, and then just move it up and down. You will notice that if you move down, from the basets, you will notice that the dome of the talus will come up, and you will see that the protrusion will actually hit the ligament. No. So if that happens, then you are pretty sure that you are not only causing an injury of your ankle in the ATFL, but also instability that could have a secondary effect on the basets. If that happens, you have to make sure you do a lot of exercises that could strengthen the anterior muscles in order to push back the talus to the original position. Otherwise, the microinstability would not happen. But your question of where do we begin the orthobiologic? As soon as you see them, you can start planning about doing an orthobiologic even as early as 2 weeks after the injury, because I think by the time it's clear to you that you have an injury, where exactly you are trying to see, and you have to inject it right at the joint and also at the ligament itself. So 2 areas, joint and ligament. Why joint? Because you do not want to cause any additional injury if there's already a microinstability. But at the same time, why you would want to do the ligament at the same time is because you would like to tighten. You would like to tighten. If it's just a grade 1, grade 2, then that means there's a lot of chance for the ATFL to heal. And then as it tightens, then it will also push back the talus back to its normal position. So as soon as you can see that and you are clear on that, then you can start your orthobiologics right away.
Thank you, Doc.
Thank you, Jan.
Doctor, do you have time for maybe a question, one more question?
Sure. One more question, yes.
Dr. Jim, thank you. For people or for athletes, let's say you have undergone surgical repair, let's say, for a higher grade lesion or tear, is there still room for injecting orthobiologics afterwards? As we said, to do some preventive or to help in any way. Are there journals that, tell us that there's a good chance of prevention in the future, even after surgical repair?
Yes, Pash. There's a lot of journal that says when you actually do orthobiologics, it shortens. If you look at the early part of the lecture, the PRP injected will shorten the return to play. So if you would like to shorten the return to play of your athletes, then you can actually include your orthobiologics early on, or even at the same time when you do your surgery. There are surgeons who does that intra-op, so that the healing would be faster, the recovery will be faster, and then the athletes can go back to their activities early on.
Thank you, doctor. And for most of the scans that you did, these are all using linear probes. No, even if when we're talking about deeper structures, we're still using the linear probes, correct, Dr. Jim?
Because it's very superficial, you can see it, except maybe for the posterior talofibular, where you have to put a lot of gels, just gel.
Like the stand-off and things like that. Yeah, just to visualize it very well. Okay, so thank you, Dr. Jim.
Thank you very much.
We'd like to remind everyone that if they want to view this lecture again, right, we can just see it at your YouTube, MSK Ultrasound by Dr. Jeimylo de Castro.
Wow. Thank you very much, and enjoy your pandemic holidays. So how are you, Tolga? Where's Dr. Tolga here? Why you're so quiet? Oh, he left already.
Yeah, I think he has clinic also, Dr. Jim.
Yeah, okay. Thank you very much, Pash, Jem, Byron, Dr. Tamar, Dr. Padmesh, and then who else is here? Dr. Setia, Dr. Siebert. Thank you for coming and joining us tonight. See you soon.
Thank you, Dr. Jim.
Hi, Doc. Thank you.
Thank you, Jem. Thank you. Regards to your mom.
Bye, Byron. Bye.
Bye.